I'm Father William Blazik, and I've had the privilege for the last 2 years of directing the Institute. So great pleasure to welcome back some old friends and a few new faces. We're excited about our topic. We chose the title this year, Conscience and Religious Freedom in Healthcare. And I'm certain you're all aware that the issues of religious freedom and conscience are very foremost in our deliberations about healthcare policy in this country, but also practical clinical decision making. We have a great panel of speakers that we're very glad to welcome here. And we're also want to express great gratitude to our sponsors. Relevant Radio was good enough to publicize this for us, and the Blue Island Community Healthcare Foundation also gave us a very generous grant to fund the speakers and the venue. And we also are very grateful to two generous families who wished to remain anonymous in their support, but they wanted to express their gratitude for God for many blessings in their life, and were very generous to support us, and we are grateful for that. We wanted to give Bishop Perry just a moment here at the beginning to say a word or two before I make the introductions. Bishop Perry, if you have a moment, if you'd give him a hand, please.
Thank you, Father Bill. Issues of conscience and religious liberty, as you know, loom large in the popular debate, the popular conversation running through the country these days, vis-a-vis conversations like this, and some of the things that are going on in the courts. And this points to something of what we notice, a disengagement between things secular and things religious. We as believers, Christians mostly, and people of other faiths, we do not decry the other side of the opinion, because we believe that civic life has something to add to the conversation on a number of topics. It's just that we don't want to be left out of the conversation, out of the marketplace, so to speak, and the debate, because we believe, as the gospel compels us, to add our piece to the conversation. There are aspects of things like conscience and liberty that are specifically religious in tone. And there are many themes that run through our scriptures, especially the Judeo-Christian scriptures, that support these themes for the life and the flourish of the community, the life and the flourish of belief, the life and the flourish of human contribution to the benefits of society. So, from our standpoint, we're not so much polemic or partisan in what we stand for. We like to be part of the whole. And I think a forum like this, a Bioethics Symposium, says a great deal about some specific and yet some important pointers in healthcare today, a very delicate part of our life, and a part of our life that consistently drums up questions and puzzlements and mysteries that are closely allied with the life of faith. So we welcome you to this symposium, and hopes that it can enlighten you on some things perhaps never imagined by you, as well as some other things that may have existed in your own consciousness as puzzlements. So you can see where the conversation is right now and where it seems to be going. So thank you very much.
Thank you so much. Well, our theme for today is religious freedom and conscience in healthcare, but we also wanted to get started today with introductory and a more basic look at ethical clinical decision making, and we have a real treat today with our first speaker, who comes extremely well qualified, practicing at Bronson Children's Hospital in Kalamazoo, Michigan, as an associate professor at Western Michigan University and Michigan State University Medical School, board certified in general pediatrics and neonatology, and an ethics background, and certified by the National Catholic Center for Bioethics for the program that they're happy to run. And so having made the long trek from the mean streets of Kalamazoo and now joining us here in Chicago, Robin, if you'd come up, we'd like to welcome her and give her a hand, if you would.
Good morning, everyone. It's not so terrible a mean trek. The hardest part was making sure my children got to the respective soccer fields and baseball things and who was on first at home. That said, I wanted to talk about, I live in the trenches, in the front lines. I am predominantly a clinical neonatologist, and we make decisions constantly. How do we do that? And I do not practice in a Catholic institution. There's lots of voices, lots of opinions. It's interesting frequently. So how do decisions get made? Ideally, one patient at a time. I don't care what the diagnosis is, until you've applied it to that individual, you don't know much about what that diagnosis means. And the goal is always the right care, right time, right place. It's pretty individualistic. It is not a global decision. All cancer patients are the same. All babies, all neonates are the same. Your health care is very personal and very tied to many other things in addition to your medical history, your family, your universe, stress in your life. There's a lot that goes into what brought you to this place at this time, at this diagnosis. So when we're making a decision, we try to have a combination of an overlapping of, we would like it to be medically correct, but we'd like it to also be ethically appropriate. We'd also like to be within the realm of the law. We would like it to be a legal decision. But in addition to that, there's something about the expertise of your physician, the evidence. What is the best evidence, the standard of care today that can be brought to it? As you see, things change rapidly with our technology. What should we use? What shouldn't we use? But the expectations, the value system of the patient impact that decision-making process. So once again, this becomes, as opposed to, oh, I have this one diagnosis, rheumatoid arthritis. What does that mean in the construct of that person in their life with the expertise or the lack of expertise of the surrounding people? So it gets a little dicey very quickly. The other assumption, of course, here is that you have a choice, that the physician has a choice, that the patient has choice. But for the choices to exist even, you have to have a freedom to choose something. And that gets a little interesting with some of the legislation that has come down today. When a government makes a decision, it's a national answer, laws. And when you're dealing with a stoplight, I think that's probably a pretty good idea. The problem is your legislators usually are not physicians, or they're at least not your physician who knows your specific issues of what's gone on. That matters. And we'll talk about an actual case to kind of give you a feel of the intricacies that can become involved. Now, truth in telling here, yes, your doctor knows the medical answers. They're less prepared often to deal with some of the ethical issues or to even be aware there's an ethical issue, in addition to some of the legal answers. So there is an inherent disconnect at some point in this process, which everyone needs to at least be honest enough when you come to the table to say, all right, how do we in fact make a decision for a single human being? So with that said, what I want to do is we're going to discuss one particularly knotty case, and I apologize. I think God made PowerPoint so that I can rearrange it until about nanoseconds before I speak. So you have, at least at the time I wrote it, a reasonable proximity of what I'm about to say. Forgive me for taking some liberties and adding a number of slides because I wasn't done. So yes, we are going to I'm going to talk about a medical case. I'm going to take the time to go particularly through two particular decision-making models, Principalism and the concept of ordinary and extraordinary medical care. We can also touch on some other things, but I wanted to get to those two, how they apply to this case, because they can come up with different answers. And of course, we'll then apply that. So here's the actual case. This is a real-life case. As a neonatologist, what I do for a living is I live in the neonatal intensive care unit. I take care of critically sick babies. Whether it's too sick for the pediatricians to deal with on the floors, in addition to obvious premature babies or babies missing chromosomes and other various anomalies. So, a very typical consult is someone who is in premature labor and threatening to deliver early. Ideally, we get to talk to them about what they're about to face. Particular consult came through that there was concern that this mom was going to deliver at 25 weeks gestation. This is literally about half-baked. Term is 37 to 40 weeks. The very edge of viability these days is around 22, 23 weeks, although we'll talk about making too many decisions based on gestational age in a moment. But 25 weeks, okay, we're pretty small, and certainly no guarantees for outcome. So when we do a neonatal consult with a family, ideally we have more than mom to talk to, we discuss the general expectations. What should happen if the baby, what would you expect if a baby at this size is to be resuscitated? And what are the kind of the general big-term, long-term outcome pictures? What does this mean? We then take it one step further to what is your baby going to look like? Are there complications from the mom? Are there complications from the neonate that we've been able to figure out that we need to also then apply to the general model that might change the percentages of how good or how bad the outcomes should be expected to be? So, with that said, national outcome numbers. There is an absolutely brilliant study, over like 45,000 babies. The NICHD, this is a huge number of hospitals, a consortium they got together, and it is quite impressive. To give you an idea of how impressive this is, when this work came out, there was an actual meeting that happened afterward between neonatologists, perinatologists, high-risk OB, and pediatricians. That's never happened, and OBs. That's never happened on the face of the planet, that all those groups got together and actually spoke to each other in the same room. Even more astonishing, last year in 2013, there was simultaneous publication of the outcome of this work group in the neonatal journals, the OB journals, pediatric journals, all at the same time, so that everyone could see how important this work was. And what happened with this study is that 5 variables were found, independent variables that had something called a p-value to say just how important they were. And they found that if you look at a baby's, not just their gestational age, the gestational age, the sex, is it a boy or a girl? It really is true the girls come out tough as nails, the boys, not so much. Their weight in grams, as well as are you single or a multiple? Do the mom get maternal steroids during the pregnancy? If you combine these 5 variables into what I call this preemie calculator, and you literally can go online and put in the individual things for your baby, this study gives you an incredible prognostic tool to be able to tell the parents survival, and even, to me, almost more importantly, or at least equally, survival with or without neurologic impairment. So you have an idea of what you're entering into, or should we begin this road. Now, as good as all this data is, if you're born at a hospital that isn't used to taking care of premature babies, it kind of goes out the window. You have to know the local data. You do have to know the expertise of the people around you. So you have to be careful. There are some limitations to this absolutely brilliant study. Limitations are local outcomes. Limitations are what other things are not calculated. I'll get to that in a second. So this is what you see if you enter into this program. You can choose, and this is just really for the edge of viability, because after a certain age we expect good outcomes. There was a weird moment a couple years ago when I was taking care of a 27-week preemie, and I looked at a family and realized, I assume a 27-weeker is going to go home and be valedictorian of their class. I'm like, wow, when did that happen? Because that's a monumental shift. I have nurses I work with who said, they remember when if you needed to go on a ventilator, they also got out a death certificate at the same time. Neonatology has changed dramatically just in the last 10 years. So it is a very exciting time to be with this. Outcomes for the particular infant that I was consulted about. 25 weeks, it's a girl, singleton, it's not a twin or a triplet or any of those other things, and mom actually did get prenatal care, has appropriately gotten steroids. Here's what the calculator showed. Survival, 82%. Pretty cool. So death, if you do the math, under 118% of them do not. Survival without profound neurologic impairment, 70%. 30% are going to have profound problems, and they do have gradations in between, but pretty amazing numbers. And I can say with confidence that at our NICU, we're a 50-bed unit, our numbers, and we track our numbers, some places don't look, we do track, and our numbers are as good or better in some cases than the national average, so I'm pretty confident when I talk with parents about, and I give them this piece of paper with these numbers on it to hold in their hands, say, this is pretty close to the reality. Just to give you a comparison, how dramatically things change in neonatology. If you're a 23-week, I ran these numbers just to see what it would look like. 23-weeker, 2 boys, 450 grams, which is not uncommon for that size and age. And there's twins. Mom didn't get good prenatal care, doesn't have steroids. Let me show you what that looks like. 11% survival. And I think that's generous, I'm going to tell you. Most of them die. Survival without profound neurologic impairment. I basically would tell that parents, your baby will have some degree of impairment. You don't get to take home a baby who's fine. It's not fair for me to tell you at 23 weeks that they're going to be just spiffy. Probably not. Now, there are degrees, but let's talk about what that means. So just so you have an idea, this 25-weeker with those numbers, that's pretty exciting. So, why are those numbers true? Just a quickie through what you get to hear about premature babies that you didn't want to know. They have ridiculously immature lungs. Even when born at term, babies often lag behind in this area. The little air sacs, at 23, 25 weeks, the embryology, they're not quite formed yet, so the actual ability to exchange oxygen, not so much. And the blood vessels that have to match the architecture of the little air sacs, it's just getting there. So this organ system is amazing, and it is ridiculously immature at that point. Things have gotten dramatically better since a medicine called surfactant is now on board, and we give that to the babies literally once they're born, right into their lungs. We also aggressively get them off the ventilator. I look at the vent now as a necessary evil, and I try to get rid of it, helping those lungs mature. So the lungs is a huge hurdle that these babies have to get through. They're pretty much born without an immune system, so even normal bacteria that are on your skin and in your gut, they can cause pathologic changes like death. So it is a big deal that they don't have an immune system. And one of the things, why are some of those neurologic outcomes so bad? They can have a bleed in their brain. The vasculature is incredibly rich in the last trimester. So it's the period of the most rapid growth. But if you've ever seen premature skin, it's kind of like tree froggy, sticky, translucent stuff. Well, that lining is also what goes along the vessels, so they break very easily. And the sympathetic nervous system that controls are the vessels dilated or contracted, it's not, the babies aren't so well wired yet. So if there's a big rush of fluid, the brain sees it, as opposed to your vessels knowing how to control that. And literally that very vasculature area of rapidly growing brain can burst. And the blood up there can basically cause holes, and you're missing parts of brain and a number of other complications down the road. So it is with great humility that I get to take care of these itty-bitty little people. And it's with a fair amount of fear that, let's admit what we're getting into. So the outcome of our current one is, as you saw, not bad in the land. What's not calculated? We talked a little bit about local outcomes. We also don't, that calculator doesn't take into account maternal complications. Does she have an ongoing infection? One of the very common reasons for premature delivery. Does she have a bad history of hypertension, diabetes? Pick something. You know, has she recently had chemotherapy? What else has gone into why is she now seeing me? And the baby's complications. Am I missing an organ system? Do we have a chromosomal deletion? Are they not growing so well? Is the placenta abnormal? Those things are not accounted for in the calculator. So it's, once again, specific patient, right time, right place. What are all the things? You kind of start to get an idea of how complex the decision-making has to be able to do the right thing for one individual person. So, resuscitate or not to. How do we make that decision? One of the main models that is taught in just about every generic ethics class, and for sure in the secular world, is something called Principalism. It was created by these two guys, Beecham and Childers. They're two white guys and lived in Ivy League schools, which I have some interesting commentary about. But the book is now in the 7th edition. Once again, come to the bedside admitting who you are and your own limitations and what your own biases are. This is where they're coming from. Basic textbook for teaching bioethics. It is also probably the Bible in most hospitals today. This is what their ethics committees are using when they get called into the mix of it's a dicey situation. And it's based on 4 principles: autonomy, non-maleficence, beneficence, and justice. And I'm going to tell you that in the United States, the main guy is autonomy. We really kowtow to me. It is all about moi. I know what's best for me all the time, and if you do not do it my way, I'm going to go doctor shopping. And this is a very interesting thing. This is now being transported into Europe and across the world with some interesting discussions, and I'm raising some hackles on a number of people. But it's not all bad. I don't mean to paint a completely horrible picture, but you have to know what you're getting into. So, preeminence of autonomy. This is the right to self-determination. And careful, once you see right, all sorts of red flags should go up because it means there's been a legal system involved, and what do rights mean, and interesting cascade of thinking. Now in pediatrics, we have some problems with already autonomy. What we do is something called best interest, and the parents are really the natural surrogates for who gets to decide for a child, and I think that's right. Most of the time, parents really are looking out for the best interests of their children. There do get to be some interesting situations. The other thing to know about this, when this was really created thinking about adults, however, and it's a retrospective decision, really based on how did you live your life? What would mom have wanted? Would she have wanted to live on a ventilator? Would she not have wanted? Would she have wanted this? So it's a retrospective decision based on who this person is. Who have they shown themselves to be? What is their value system? Pediatrics, it is a whole different ballgame. And in the case of an extreme premature baby who has not yet had life outside the womb, it is really stretching the prospective indications. It's an appraisal then of what is the future going to hold. Now, interestingly, the Supreme Court in a number of cases has weighed in on this, and they have said parents, and I'm quoting them, may be free to become martyrs themselves, but it does not follow that they are free in identical circumstances to make martyrs of their children. They do not get to simply say, I'm done with you. Now, two prominent authors, Dr. Griswold and Faneroff, who is a lawyer, actually said, physicians are empowered and indeed morally obligated to act in the best interests of an infant or child, which may lead to conflict with the parents. And you better believe there gets to be some interesting situations. So, in applying principalism to patients in general, you can already see there gets to be some interesting conundrums. Non-maleficence requirement that caregivers do no harm. Beneficence expectation that the caregivers will do good. Basically embracing the long-held belief of physicians do no harm. We take that as an oath. It is a balance game of doing to a patient, or not doing just to someone, but for them. As a critical care doc, this is a line that I will tell people up front. I promise to be honest with you, I'm going to do for your baby. If I think we're crossing a line that we're just doing stuff to them, I have to wave a red flag and say, wait a minute, we have to rethink this. Are there risks that outweigh the potential benefits? This is a calculation that we do constantly all day long with every prescription we write, with everything we do at the bedside. That weighing of risks and benefits is almost inherent in how I walk and breathe. It has to be. But think about basic stuff, vaccines, which have become not so basic, and we'll later conversation get into, but or things like chemotherapy. That risk ratio balance of, you know what is the chance this is going to actually cure and give me a valuable life, as opposed to this is going to make me miserable up to the nanosecond I die. You have the option of maybe not choosing that. Not unreasonable. So when we talk about beneficence and non-maleficence, though, for extreme premature babies, English is my first language, wow. Concern that medical treatment will prolong suffering or death is a big issue. Because quite frankly, I can make a rock look like it's got a vital sign, and I can make it look like it's alive for a really long time. Doesn't make it the right thing to do. So once again, with great humility, we have to go into this. The fourth principle of justice calls for fairness in treatment. Please don't experiment on your patients. They're not guinea pigs. Access to health care, trying to make sure we have this to everyone. Resource allocation, excuse me, not so much in my world. And people have been very consistent about saying that, lack of insurance is not a reason to not resuscitate or not treat a baby. I'm a referral center. I have no idea what anyone's insurance is. I'm delighted if they have some. But we take care of all comers. That's just not part of the equation. Excuse me. So that's a little bit about principalism. I want to now compare it. There's something else. Ordinary, extraordinary care. Origins really are from the church. The existence of a positive moral duty of caring for health and life, one's own and another's, has been recognized since the origins of Christianity. And you can find this in the writings back of St. Basil, St. Thomas Aquinas. Who really brought this forward was Pope Pius XII, 1957, in a discussion with anesthesiologists, really made the distinction between what's ordinary and extraordinary care. And then in the Sacred Congregation for the Doctrine of Faith, the Declaration on Euthanasia in 1981, of which now St. John Paul II was instrumental in bringing this forward to say, for the first time in a magisterial document, we also have terms of proportionate and disproportionate, so that there is a principle of proportionality. We don't have to use all things all the time. Just because you have a hammer doesn't mean you have to use it all the time. So you can think about what is the right medical treatment to be applying to a human being. Now, it is an understood basic principle that life is intrinsically good here. That is where this model starts from. There is a moral obligation to use medical treatment that is ordinary, meaning tolerable side effects, physical, emotional, social, financial. You do not need to sell your family, the farm and everything around you to be able to afford medical treatment and call that reasonable, ordinary stuff. These side effects. You do not need to take a drug that makes your face fall off. This is, you know, probably disproportionate to what you're treating. Think about what you're doing. There's not automatic application here. It is reasonable to not use things that are excessively burdensome, objectionable features, the side effects, negative consequences. Defining the burdensomeness is really important with this. Once again, degree of risk compared to, is this going to succeed? Bad side effects, physical consequences to one's life, excessive pain. Treatments judged morologically or psychologically repugnant. When I'm treating Jehovah's Witnesses, the thought of blood products absolutely drives them around the bend. On the other hand, I can tell you, I've had more than one mom say, thank goodness you went to court because I got to still have my conscience, but you did the right thing for my baby and gave them a transfusion. So being very careful to ask, what are the values? What do they have? Sometimes people find their value system as they're going through someone who is very sick. They didn't know they had a value to begin with. And all of a sudden they're like, whoa, that's icky. Like, well, let's talk about why. So hugely important in how you decide how to apply medical care. As you know, say excessively expensive, no. The key to this, though, which is very different than principalism, is that one does not ever judge a life excessively burdensome. One judges a treatment. This is important because under the rubric of principalism, you could argue for things like physician-assisted suicide, because the autonomy of the patient says, I want this, you must help me. And under this rubric where it says, no, your life is important, all medical treatment is not on the playing field, how about I treat your pain? I will do that. So very different outcomes, both absolutely practiced frameworks for how to make a decision for a patient. So this just kind of is the summary slide. Principalism, primacy of autonomy. In pediatrics, its best interest provided by the parents. Do no harm. And justice, please keep it legal. But also looking at some of the other resource allocation issues. As opposed to ordinary and extraordinary medical treatment, which basically, first tenet is all life is good. There's an ethical obligation to use treatment that's ordinary, which is likely to succeed. There is no obligation to use treatment that's extraordinary, that is excessively burdensome, and are unlikely to succeed. Now, remember back in the beginning, because we're going to have to apply these to this actual case. How do we do this in the medical setting, overlying ethical, medical, legal, expertise, evidence, and expectations? So the parents, we have this conference with them, we present all the numbers, and they say at the end of this, we want a guarantee. Okay, sports fans, you don't get a guarantee with children. I've checked under the armpits, I've looked in all the places. There is not a place that gives you directions. There's no guarantee that they're going to be fine. There is no guarantee that they will be perfect. There's not even a way to return them to where they came. These people were dead honest. They wanted a guarantee that their baby would be perfect, but they didn't want us to intervene. Now, I have to say, I was not the direct consultant on this case, so this is not my bias in this. My partners, who are not particularly religious, their conclusion was, if you call me, I am going to resuscitate this baby. Given these numbers, I could not possibly, ethically, morally, legally, walk away from this child, this real life that has a real chance of living, and living quite well, thank you very much. The parents' conclusion was, I don't want, if 25 weeks, and we'll talk to you in about a week or two, maybe, because then I will say the numbers change. But remember, I said, 27 weeks, I'm expecting them to be dancing down the hallway and chasing and running around at recess. But I can't guarantee that. No way, I can't guarantee that with a term child. So it was a tad unreasonable. Our ethics consult was called, and in a prior case where the parents basically came to that same conclusion, the ethics team upheld the parents because they were using the model of principalism. Once again, we went back to the family and said, if we are called to this delivery, we made it very clear to the OB nursing staff, if you call the neonatologist, we are coming to resuscitate the baby. The family left AMA against medical advice. I will tell you to this day, I don't know what happened to that child. I don't know what happened to that family. But what I need you now to think about is, what if the government had passed a law stating which baby to resuscitate or not? Because remember, we were told in our current healthcare mandate, you have to read it to find out what's in it. You can't make this stuff up. That, is there at some point in there someone else who tells me what I can or cannot do? As a physician, as a parent, as someone who's going to eventually need, or has needed, our healthcare system. You better believe this is scary times, and what I need everyone to do in all their different walks of life is have your head up out of the sand, because we have got to be careful about what is being told to us in various forms of media, and we have to ask questions. What does this mean that you're passing a law that could potentially get in the way between an individual patient and what a physician and that patient decide to do in this situation for this human being? So what you've noticed is that ethics is not a sideline, couch potatoes kind of sport. Doctors and patients make multiple treatment decisions every single day. The question is, should an issue where individual specifics and multiple complex variables matter be nationally legislated? In medical ethics, I kind of love this slide. It says, what people think it looks like is this lovely straight arrow, and what it really looks like, you are here. Welcome to the knot. But that's okay. As long as we have the ability to laugh at ourselves and once again admit our biases and how we come to the bedside, there's a chance that I still believe we figure out what's the right thing to do for each other. Because of something else that we didn't talk a lot about today, there's that natural law, that embedded intrinsic knowledge of how do we want to treat another human being. And I think that does frequently reign supreme at every bedside that I go to. People want to do what's right for each other. But if we can take the extra step to gain some additional frameworks of how to hang the questions, it helps people to ask then that next question. Why should we not do this? Why should we? And how do we decide? And that's what today is an invitation to come do. Ask that next question, because I think we should keep this a very individualized, non-legislated sort of thing. And I would love to open it up to your questions. Thank you so much.
Thank you for a really wonderful kickoff and introduction on those topics. That was a wonderful, wonderful start. And we do want to field your questions. We have about 10 minutes. We're recording this to post it on the web, so we would ask that you wait until a microphone be brought to you so we can make sure we get the questions as well as the responses. So why don't we start right in the back here?
Hello.
Hi.
Hi, this was a great talk. My question as a medical student is what advice would you have for students in training to develop this type of practical wisdom in terms of being able to apply these principles in practice to individual situations?
Great question. Hi, I'm a recovering medical student. Medical school about beat the humanity out of me. You're really trying to survive. So the fact that you can ask the question that you're here today is a great start. What I would suggest is in between the alphabet soup of, oh gosh, I have to know what a hematocrit is and blood volume and all the other things that you need to incorporate, challenge yourself to read something like any of the ethical literature that's out there, whether it's the Hastings Report. The National Catholic Bioethics Center puts out things all the time. Challenge yourself to ask the questions of, is this right or wrong? It will make your attendings crazy. That's okay. But when they start proselytizing at the bedside, and they say, oh, we are just going to do this, ask them why. Ask them if they ask their patient. A huge decision-making moment for me when I figured out that I wasn't going to go into pediatric intensive care was really because I saw an attending behave in a way that I was like, please God, I can't live this way. There was 3 babies at the same time who came in. They were victims of child abuse. They had been flung against walls and various things, and they were destroyed. And one particular baby, the attending physician said, of course we're resuscitating. And I remember thinking, did you ask Mom? We just came up from radiologist who said that is the worst looking MRI he's ever seen in his life. Because I love the dignity of life, this is a single parent now because Dad, who knows where he's going to go, jail. I don't know what the right decision is, but did you ask her? And the answer was no. So I beg you, as medical students and people on your way up, challenge yourself to ask the questions. Should we be doing what we're doing? How do we know it? And is the family part of the conversation? Is the biggest single thing you can do to maintain your humanity? And also, and recognize that, yeah, you probably won't agree with all the decisions that are made, but if you have the humility to keep asking, it goes a long way. Great question. Others?
We have a question up here in the front.
Thank you again for your wonderful presentation. I wanted to ask you about and for you to comment on your role as an educator. You know, the dealing with, say, the case that you had shared with us, you know, that your perspective in being an educator of the parents, of your team, you know, a leader in asking those good questions. Obviously, you had some support teams around you to help with that decision-making process, but, you know, your specific role. Would you comment on that, please?
As an educator, I kind of look at myself as incognito. I love just very quietly coming up to the bedside and hanging out, asking the nurses, how you doing today? When the medical students or the residents come in, and I obviously looking at a tad sleep deprived, how you holding up? I think the best thing I do as an educator is probably the non-formal stuff. When they see me hold a baby until death because the parents haven't been able to get there, or I sob with a family, or the laughter on rounds. Because I can't do this with a straight face, it just doesn't work. It's the role of how do you live your life, and if you can't walk the walk in how you live and breathe, your voice really doesn't carry very much. So hopefully, as then you guys go out, how do you educate your peers? They want to be like you. And they want to follow in your footsteps, is always my hope. It's also very humbling because I'm thinking at the end of the day, they didn't want to follow that. But you hope. And you kind of, so the best thing hopefully I do as a teacher is all of the non-formal stuff, in addition to, because then by the time I get to the actual lecture and the teaching sessions, they have a reason to listen to my voice, because otherwise they actually don't show up. Although bribery by pizza is still always a good tactic. It worked in med school, it still works now, or chocolate. So once again, how do you go about living every single day? It is truly my greatest honor that the nurses come to find me when I've got a patient who is in danger of not living, and how do we help these parents live through the unthinkable? And they will often find me, and it is truly with a sense of great love that they know I have for them as well as these families. So how do we educate each other? You have to show up and be a real person. It's probably the best thing I can say.
We have one on this side, and then we'll go to the other side of the room.
First, thank you for your presentation. You're called before a congressional committee
Oh boy.
to testify on how to modify the so-called Affordable Care Act.
Mm-hmm.
Your challenge is that many people have signed up for it. So that helps the opposition. Your job is to give the people who are inclined our way the wisdom they need to help turn this thing around.
Boy, if I had Congress's ear, the first thing I tell them, stop passing laws. But number two is really, okay, we have, you admit what's good about what we currently have. Here's what I want to keep. I love being able to care for everyone. I absolutely admit that. There isn't anyone I don't want to care for. The problem is, how do I care for each individual person well? And intentionally adding emotional issues, baggage to this, to a law, is wrong. Specifically, contraceptives, because let's admit that everyone's at war over this. Don't put it here. We can argue about that offline. We can do that separately. Take that off the table. All those things that have, because by the way, let's also admit that Planned Parenthood is who sponsored that and who put it in. And so let's fess up who's getting financed over a whole lot of things. And we can go back through the writings, and I pretty good footnotes that show that they want that. So let's admit, I'm going to tell you, Congress, my first thing is that I think all human life is valuable and good. So now how do I care best for each individual? And it might be by empowering the physician and the individual. And please do not legislate stuff that is overreaching that relationship, that covenant relationship between a doctor and a physician. Let them decide. If your legislation cannot pass just that single test of it might get in the way of a physician and a patient, then it shouldn't be legislated. Traffic light, yes, not an individual decision. That's not okay. That's where I would start, and then tick off individual points from there. Reasonable?
Thanks. I'm just wondering, what are some good reasons to not resuscitate? I think every time it gets brought up, I'm very confused. Even like the last example of the abused child, like what you mentioned, like the MRI being very dangerous, like you're talking about brain activity, or because wouldn't we still value that life?
Absolutely. Yeah. Once again, the value judgment is being made on the treatment, not the value of the life. At least from how I start making my decision tree. Let me give you a slightly different case. If a baby is too premature, we're borderline viability, there is a chance that, there's a significant chance that the baby will be significantly damaged. There's also a chance I don't have equipment small enough for this baby. I often will look at a parent and say, the first decision tree is if my tubing, if I can't put this baby on the ventilator because I literally don't have things that are small enough to go in, we stop right there because I don't want to do harm. I don't want to prolong suffering. Now, say that we're able to get tubing in and we're farther down the line, but the baby's not responding. And this is true for all parts of the case with the baby whose brain had been destroyed. The child wasn't responding. The baby wasn't breathing. The baby wasn't waking up. And this is something that I think you have to be very transparent with families about. This is a good, here's an appropriate response to treatment. Here's a non-responder. I can't make someone who's not responding to what I'm doing. This is my Mary Poppins bag of tricks. Here's what I've got. Here's where medical technology stops. And I'm all about, I'm good with praying, and I have prayed with families at the bedside. But the ventilator is not the prayer. It's not God. And sometimes I have to admit that the only thing I'm doing is now prolonging suffering. I can't restore them. I can't, and how do I now keep them out of pain? How do I help value so that they're not suffering needlessly? How do I keep them in your arms? Less tubing. How do I let you hold your baby for as long as you get to, and yet not admit where I can't fix this? Their lungs, we have some kiddos, they literally outgrow their lung tissue. What do I do now? And being very, very honest about what our limitations are. So that transparency about here's what I expect response to look like in a reasonable time frame. Here's what non-response is. That honesty is key to all forms of medicine. Does that make that a little bit clearer? Okay, good, thanks.
We'll take one last question from back here for this section, then we're going to have a little coffee break.
Thank you so much for coming to speak. You talk about how the laws that we have often get in the way of the doctor-patient relationship, which is sound and makes a lot of sense. But if we don't have that, then that necessitates the need for an ethically educated physician, which, considering the wide breadth and number of physicians we have and educational levels, may not always be the case. And so if we were to remove, any sort of legislative control, then you may have a bunch of doctors making bad decisions.
You bet.
How do we deal with that?
Great question. I'm not advocating anarchy. That would be a bad day. So once again, there does have to be a balance game. Because certainly, well, first of all, to the first part of it, ethics should be part of our medical education. It was not. It was non-existent when I went through med school. Oh God, I'm old. I realized I was officially old when I used an expression. I was teaching a medical school class and I was talking about DNA looking like a phone cord, and I went, oh my gosh, you've never seen one connected to a wall? I am officially an old person now. Great. So having ethics as part of the medical curriculum, I think is crucial. I think we have to continue, especially in our society, which does lovingly encompass so many different faiths and value systems, that some general guidelines are good. I still kind of like the 10 Commandments. I think do not kill rocks. I think that's a good idea. By the way, truth and honesty, I'm a Jewish convert to Catholicism. To kill there's 3 different words in Hebrew. To kill in the Commandments is to murder, which is different than to kill in battle or to kill in self-defense. Those are 2 different words. Just thought I'd point that out. So I do think that you do need some form of government, and I say I don't think they should be gotten rid of, but I think everyone needs to know their place. I don't want to be in charge of what's going on a national procure the borders sort of conversation. I've got someone at the bedside I need to go see. Government needs to go back to the rightful place and not have overreach. So I do think that there's a balance game to be won. But if we don't speak up, it seems like that's going to creep into my realm. Back off. And so that's why we have to stand up and be able to speak quite forcefully when I think you've overstepped your bounds. I don't think government's inherently bad. I think it needs to be held responsible for what it should be doing and what it should not be doing.
Let's give a hand for another wonderful presentation.